Good morning, ladies and gentlemen. I thought we'd just sort of open up this time, rather than go straight into various presentations, just to talk a bit about the LMC. Hopefully all of you know who I am, and hopefully all of you know who the LMC is. But it's quite interesting when we meet people and talk to them. Quite often, people that we don't engage with very regularly will ask, well, what exactly is the LMC and what actually do you do? As you know, we've produced a leaflet which describes in detail what the LMC does. That was produced mainly because I kept going to meet my mother-in-law and explaining to her what I did when I wasn't being a GP, and she never quite understood it. And then the next time I went, I'd be asked another question. So hopefully everybody in this room knows what we are. But I thought I'd also talk a bit about today about what we do on your behalf. So we are a statutory body. There is an LMC everywhere in the country. So we represent GPs at local level, but we are not the trade union. That's the BMA's role. So there is a requirement in the Health and Social Care Act and the NHS Act before that people need to consult with us. So we get lots of organisations, whether it's now CCGs, area teams, hospitals, who will look for, well, what do the GPs think about X, or what's going to happen if we do Y, because it will have an impact not only on the GP's working life, but those of the practice managers and your practice organisation. Also, I see our role as being much broader than, there are some LMCs in the country who believe their role is just about pay and rations. I think our role is about leadership, is about informing you, distilling what we think is important information, and somebody sends you those long emails which go on and on and on, which you can choose to delete if you want, but hopefully that distills a lot of the information that we see into bite-sized chunks that are helpful. The only abuse I get is usually from my wife, who says they're far too long. We're here to support and advise you, and we spent a lot of time doing that with individuals, but also within partnerships, and increasingly with localities. We're also here to defend, and that's not defend the indefensible, but part of defending people is we work in a very complex system, and GPs particularly feel quite vulnerable at times, and there are all sorts of things that happen, and with hopefully the experience we have and the breadth of knowledge, we spend a lot of time defending the profession from the merciless attack that we get from the media at times, but also supporting and defending individuals. Hopefully also we see our role as to inspire and innovate, and that is about what today is I'm not here and nobody else is going to tell you that you have to do X or Y, but we're in a period of great change, and I believe the future's quite exciting. I think there are lots of things we could do, but there are so many options that I think it's a bit like we're rabbits in the headlight. We don't know which way to turn. And the government will come out with an increasing number of pronouncements, and some of it is how do we use that to our advantage to make our practices stronger and better and provide good services and not just get demoralised and downgrade the services we have. So you'll probably hear this repeatedly today, and hopefully you will recognise all this list. So it is a time, certainly in my 25 years of being a GP, that there is more angst and more people feeling that the whole world is caving in on them. And that's caused by workload that's increased exponentially and stress. And that's not just GPs. Practice managers are feeling with all the reduced bureaucracy that's going on in the NHS that they want more and more forms filled out, more and more ways of doing things, none of which seem to be practical, pragmatic or simple. I may be unusual, but I actually enjoy being a GP, and I think some of what's happened over the last 5 to 10 years is the enjoyment of being a GP is being eroded, and going to work every day for some is becoming, rather than a challenge and you get lots of reward by doing a good job, it's like swimming through treacle. Dumping of work. I have yet to meet a GP in the last year or so who doesn't believe that everybody else is restricting their services and pushing the responsibility back to general practice. We were promised with the 2004 contract that we'd have reduced bureaucracy. Each successive government is cutting management costs and saying that will reduce bureaucracy. I don't see much evidence of it. All I see is people keeping hold of what they had before and adding new layers as well. CQCs come in. We work in a lovely part of the country. We've got high quality general practice. We've got well-organised practices, yet recruiting and retaining GPs is becoming increasingly difficult. And there are several practices who've been out for recruitment and are failing to find anybody who's suitable to fill those posts. There is also, as you know, income falling. There's a huge problem in April with payments, with the enhanced service payments, and are they going to survive, aren't they going to survive? And SBS, who took a lot of the blame for the payment systems, but actually it wasn't all their fault. And now practice managers sitting there with looking at invoices, looking at payments, and you can't marry up one with the other. And there's huge sums of money floating around, and you're just saying, well, what's that for? What's that for? 111 was a fantastic invention. Solved lots of problems. Far few people are coming to your practice. People are much clearer what they want to do. And as a bonus, you get sort of 12 pages of unintelligible stuff, which is supposed to help you manage the patient in a seamless way. Out of hours, we've got some really good out of hours providers, but in some areas, out of hours services are not as good as it should be. And what's being dealt with in out of hours is very much holding things and bouncing it into practice the next day, rather than providing a 24/7 service, because despite what they say in the media, there is a GP service 24/7, and it's how out of hours service respond to those demands. Patient expectation is rising. Patients want more and expect us to deliver more, not to do with patient need, but it's to do with patient want. And also, part of that is driven by the government, who keep promising more without putting any resources into it. Community services are a major problem in most areas, where they seem to be further and further away from practices, and there seems to be less integration, despite a lot of what's talked about nationally about to deliver effective services. We need really good integration between practices and community services. And we're fortunate to have some really good premises in our area, but actually there are some practices who are bursting at the seams, don't have adequate premises, and there doesn't seem any light as to where we are going to get new premises when we're going to move all this work out of hospitals into the community to deliver it. So, we faced major change in April. The Health and Social Care Act was implemented, PCTs went, SHAs went, CCGs came in, education and training came out of the Strategic Health Authority and went into, with the deanery, went into Health Education England, now called locally Health Education Wessex. Public health moved, and we've got this wonderful thing called a clinical senate, which people are still trying to work out what it does. So the whole of the NHS seemed to change, except general practice stayed where it was, and we have to fight with the consequences. So as an LMC, all our networks and relationships have been turned on their head, and we have to establish new ones. Quite a lot of the people who worked in the previous organisations are in the successor organisations, so the personal networks have remained, but it is a major challenge. One of the things I believe we're quite good at is communication, and that is key to the role that we do. So we spend quite a lot of time on face-to-face, meeting individual GPs or practice managers, talking to small groups. We go to quite a lot of practice manager groups. We go to, basically, if you invite us, we'll try and come. And we hold quite a number of conferences like this to try and inform you and communicate what's going on. The telephone we use quite a lot of, but probably less than we used to, because more stuff is done by email. Email, I get over 100 emails a day, and other members of the team get quite a lot, so we spend a lot of time responding to requests from emails, both to individuals, but also we send out group emails, and hopefully, although we're mindful that we may send you quite a lot of information and your inboxes are getting quite full, we try and measure what we send you that we think will be useful and helpful. And finally, our website. There is a lot of information on our website. I personally believe the website has become a bit disorganized and a bit cluttered and not as easy as it should be to find stuff. And over the next 3 to 6 months, we're going to have a major look at it and revamp it to try and make it more user-friendly and more helpful. Over the last year, we've issued a number of guidance documents or major bodies of emails. And there's just a list of the stuff that we've identified that we get lots of questions about, and therefore we've tried to use our expertise and pull people in who know more about it than we do to try and give you some simple translated information. Representation. We represent you. We are a recognised body by statute. One of the accusations of LMCs is that we're pale, male and stale. So last week I went to Portugal. My wife thought I was going to play golf, which I did do, but it was mainly to try and get a tan so I didn't look quite so pale. There are quite a lot of male doctors on the LMC, but actually we're getting increasingly number of female doctors. And stale, I would hope you don't think the LMC is stale, and if we are, that's for you to challenge us, because we need to react to what your needs are. But over the period of 10 or so years I've been working at LMC, increasingly we've looked to be proactive, to try and look at what the agenda is both locally and nationally, and help you and give you the information to meet that. So we may be accused of being pale, male and stale, but I'll leave you to decide whether we are or not. There are committees in each county who meet regularly, and they hold us to account for the work we do on your behalf. We spend quite a lot of time working with the GPs in training, because it's no use learning what the LMC does in the latter half of your career or when a problem arises. We need people at an early stage in their career, and also a lot of the stuff we're deciding is their future. So we need them to engage with us and be part of our committees and working with us. And that goes with the GPs in the first 5 years. The male versus female ratio, 70% of trainees are female. There are an increasing number of female GPs, which provides quite a diverse between part-time, full-time, portfolio GPs, all sorts of things. And actually increasingly male GPs, a number of them are now part-time. So our committees hopefully reflect that. Also, there is, whereas it used to be 95% partners with a few salaried doctors and some locums, increasingly partners, salaried doctors and locums and salaried GPs are bigger groups, although we're seeing a trend that we're moving away from salaried GPs. More practices are advertising for partners rather than salaried GPs. And practice managers. All the LMCs have practice managers sitting on, because they are critical to a lot of the stuff that we're trying to do, working with GPs and practices. Because a lot of the stuff we're going to talk about today doesn't just involve individual GPs. It talks about the system and the practices as part of that. Part of looking at representation, we have constitutions, which we have sent out to you. I'm sorry, those are really boring documents. I find them really boring, but we have to have them, and you are the LMC. You are all members of the wider LMC, so we have to consult with you. A bit about support. We do support people in difficulty. Hopefully none of you have gone through performance committees and performance procedures, but they are incredibly stressful and incredibly difficult for individuals. Where something serious has gone wrong, that's one thing, but some people find themselves in the system where less serious things have gone on, but there are investigations that are taking place, and if you don't believe anything has majorly gone wrong, they are probably just as stressful as the people where serious things have gone wrong, because people are looking at your practice, looking at your performance, and they can be quite difficult. We also, in terms of supporting you, like to make life easier, and I'll talk a bit about the colleague feedback and the patient feedback, and there's a press release that's going out today, which is in your packs, and I'll talk about that in a minute. Revalidation in many parts of the country has been a massive threat, and people have found it quite challenging. Hospital sector have found it a major problem. I would hope the work we've done and the information we've given you will make you realise that revalidation should be part of what you were doing previously and shouldn't be a major hurdle to jump over. And we're going to talk a bit about burnout and stress, which we think is a major problem. We've been doing some work on that. In terms of revalidation, we've been working with the RO, the responsible officer, and the appraisal service to make sure we're all singing from the same hymn sheet and we understand what we are saying. And we've put guidance on our website. We've done some podcasts on the website which hopefully explain things in simple terms. And today, going on the website, somebody's going to talk a bit about a locum toolkit. Michelle will talk about that this afternoon. And we're meeting with the ROs and the appraisal teams regularly to try and make sure that any problems that exist are addressed and don't escalate. The colleague surveys. So GPs have to do this every 5 years. So far in Wessex, there have been, using the My LMC one, there have been 1,150 GPs who've completed this. So that's 21,000 people have completed a colleague survey for somebody else. The scores for that are excellent. People generally, if you put 1 as poor, 5 as excellent, they score themselves lower than their colleagues score them. But it is quite noticeable that partners score higher than locums do. Now, that's not because locums are bad and partners are good. It's because the more people know you, the likelihood is the higher score you get. So with locums, we try and give them the benchmark that benchmarks them with other locums, not with partners. If you just look at the questions here, it's in your pack, so you can look at the absolute answers. But if you take 5 as being excellent, you can see that these are the average scores of over 1,000 GPs. And I can assure you that not all the reports that come in have everybody marked as excellent. There is variability, which means that the vast majority of people are doing really well. There have been 3 or 4 surveys out of the 1,000 where there have been inappropriate or negative comments, and we moderate them, we look at them all, and some of them have quite difficult comments which will go back to GPs, and we sometimes contact GPs and talk them through it and try and support them so that they are aware of what's going on. The patient surveys, these results are why we've done a press release today, because if you read the national media, GPs are overpaid, they're lazy, the patients don't like them, and we're basically rubbish. These surveys we've done, so 750 GPs have done them in Wessex, and that's over 30,000 patients. So I'm not an academic GP, but I'd have thought 30,000 is a pretty good sample to look at. And the results are quite stunning, that despite what the Daily Mail may think of you, that's not what your patients think of you. So looking at the results across Wessex, our results are consistently higher than they are nationally. So our patients think more highly of us. You know, I will draw your own conclusions of that, but I think we've got very good general practice. Doesn't mean it's universally good and we should all be very complacent, but generally excellent. So the conclusion to that is we've got good quality, our patients appreciate us, and if you read the press release, you will see what the figures are for various questions about trust, about knowledge, about engagement, and they are very good. Sessional GPs, there are a lot of locums and salary GPs in Wessex, and we've been looking to represent them and have more of them sitting on our committees. We're looking at a sessional doctor conference, and we bid for funding to do this locum toolkit, which we'll be telling you a bit about later. I've talked about the deanery. We've done a number of conferences over the year, and these are the sort of issues that we think are quite relevant to practices. So we've done a number of things on safeguarding. I talked to somebody a couple of weeks ago who was looking at CQC visits, and they were saying that they were surprised that CQC was so interested in safeguarding. And I felt like hitting my head against the brick wall, because either they don't listen to what we're saying or they don't read what we're saying. You know, safeguarding is a really key issue, what CQC are going to come and ask you when they come to your practice. So, you know, just please ensure that you and your staff have an idea of what safeguarding is all about. I've already warned Richard, but we've given some advice about CQRS, but care.data, and there are a whole load of other things which I think are causing huge problems to practices, because it's unclear to many of us about quite what it is, where it's going, and where we sit. We're being pulled in all sorts of directions. We've done a couple of cancer conferences, we've had IT conferences, we had 2 practice manager conferences, and of course there's today. Practice managers are critical to practices, no more so than in the present time. Increasingly, we're seeing partners going and hiding in their rooms, head down, thinking, if I'm just in here seeing patients, the rest of it will go away. I think most practice managers will realise if they go to their rooms, close the door, it doesn't all go away, because there are all these partners banging on the door saying, what are you going to do about this? What are you going to do about that? So we tried quite hard to support practice managers, both with the Practice Manager Conference, with the PM supporters, which I'll just briefly mention in a minute, and going to practice manager groups. Through our education and training arm of the LMC, Louise has set up the Practice Manager Supporters, where there are 7 experienced practice managers who we fund some time to help and support both new practice managers and existing practice managers. And again, there's some comments from people at the bottom, but even in the early days, we think that's proving to be quite successful. The area teams are now bigger because they've gone from PCT size to county size to the 2 we deal with being Dorset and Hampshire and the Isle of Wight, and Bath, Gloucestershire, Wiltshire and Swindon. They are much bigger, and inevitably the primary care departments are more remote from practices than they were before. So many practice managers have had great difficulty engaging with them to get things sorted out. So we've worked quite hard to engage with them, and there are lots of discussions going on about GMS contracts, PMS contracts, but also about what's happening to the directed enhanced services and premises. Clinical commissioning groups, and I'm pleased to see there are some CCGs here today, and contrary to what's written in some of the things, they're not the enemy. They don't represent GPs, but actually they have quite a lot of influence and sway on where we're going, and we need to work with them. So we meet regularly with the chairs and the accountable officers. We spent quite a lot of time working with them on their constitutions. We help them with elections. We're having discussions at the moment about the enhanced services, what is going to happen to the existing ones as they review them and move towards forming local contracts, and how they're going to deliver their responsibility of supporting general practice. Part of their statutory role is to improve the quality of primary medical care. And our view that is about supporting general practice, not going around with a big stick beating you all up to say improve the quality, because that's what we've been told to do. Also about integration. Everything that's written nationally is about integrating services. That's the way you get efficiencies, that's the way we deliver better quality care, and we work more closely. And part of their role has got to be about, so how do they help that happen? And for many of us, it's about community services. How do we get community services better tied into practices, delivering what we think locally is needed rather than the agenda set in Whitehall? Acute trusts, there are 11 acute trusts in our area. We are meeting them regularly and trying to complement what the CCGs are doing, because we're not the commissioners, but quite a lot of what hospitals decide to do has a big impact on practices. It's not just about the repeated inability to write a fit note or the inability to complete a discharge summary, but there are lots of other things where they change the way that they deliver their service and just somehow think that general practice will pick up the work that they no longer want to do. Education and training, again in your pack through the Wessex lead, Louise has put on loads of education and training which hopefully people have seen as being valuable and helpful. This is mainly focused at practice managers, their staff, not at GPs. Although we're looking at, I think, GP education, there is generally quite a lot out there, so we don't want to duplicate or tread on people's toes, but we want to help and support you. So what about next year? So we've looking forward, and there are loads of work streams that we think we need to carry on and deliver on. We also need to respond to what GPs and practice managers and practices need. And that's what's today about, to evolve the thinking about structures, because I think we're past the tipping point. I think the option to do nothing is no longer there. I think most of us would realise if we just sit back and just wait for things to happen, it's a bit like waiting for a train crash to happen. In other times, it's been quite clear what the route forward is, and I think today is about trying to give you some options, because I don't think there's a clear route forward that's the same for everybody. And I think there are some exciting opportunities, but I think there are some disaster scenarios. So hopefully today will be useful. And also we will use it as part of getting a sense of what you feel and where we need to develop our services over the next year and what we need to do to meet your needs. Because essentially our role is to meet your needs. Thank you.